Esteemed faculty and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on the behalf of the entire team at Emcure. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Professor Praful Kerkar sir. Sir is Emeritus Professor at SET GS Medical College and KM Hospital, Mumbai, Consultant Interventional Cardiologist at Asian Heart Institute, Mumbai. He is former Guidelines Committee Chairman of CSI on CSI Guidance Document on Acute MI and HF Care during COVID. Chairman of Board of Studies of Maharashtra University of Health Sciences. He is former Chairman of Pinnacle India Registry in collaboration with ACC, former President of CSI Mumbai chapter and organizer for CSI Con 2018. He is investigator of landmark clinical trials like CREATE, PREDICT, TAO, Paradigm HF, Paradise MI, Select, SCORED, Impact MI, ZEUS and Surpass COT. He is national leader for the Paradise MI and Surmount MMO trials. He had several hundreds of publications and presentations in national and international journals, meetings, including prestigious orations and awards. Thank you, sir, for accepting our request to guide and support us as esteemed course director for this program. Our distinguished moderators, Dr. Pravan Suri sir and Dr. B. Vinod Kumar sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our moderator for today, Dr. Pawan Suri sir. Sir is Chief Cardiologist at SGL Super Speciality Hospital, Jalandhar, Punjab. He is Vice President, Council of Super Specialists, Jalandhar in 2020-2021, member of the Editorial Board of MAR Publications in Cardiology, ex-member Editorial Board of JK Healthline. He is recipient of the prestigious Award of Honor from Governor of Jammu and Kashmir, Best Postgraduate Student Award, Excellence Award by MIDI, and Best Case Award in LWSIC. He is also recipient of Best Cardiologist Award from Times Now, Harmony India Award for Social Service during COVID era. He is National Faculty and Chairperson of a live case IJCTO in May 2025. He is investigator for multiple national and international trials like landmark trials, Nature, Real, Rosulate 2 study, and he has published over 51 articles in national and international journals. Thank you, sir, for joining today. Let me have honor to introduce our second moderator for today, Dr. B. Vinod Kumar sir. Sir is Associate Professor and Consultant Interventional Cardiologist in Sri Ramchandra University, Chennai. Best Outgoing Student, NPV Ramaswamy Udayar Gold Medal recipient. He is first assistant in first successful TAVI via trans-aortic route in the country, a boon to valvular heart disease at Sri Ramchandra University in 2016. First assistant in leadless pacemaker implantation at Sri Ramchandra University. Organizing secretary for recent updates in cardiology at Le Méridien Hotel, Dubai 2018. Paper presented at multiple conferences. He is also invited as faculty at various conferences. He has multiple papers published in reputed journals and he is clinical investigator for various major clinical studies. Thank you, sir, for joining today. I would also like to take this privilege to introduce our speakers for today. Dr. Abhishek Saklecha, sir. Sir is consultant interventional cardiologist and director at Cath Lab, Symbiosis University Hospital and Research Center, Pune. Topic he is presenting today is complex PCI case with a multidisciplinary approach, and theme for today is calcium modification during PCI. We had second speaker, Dr. Shashivardhan Janjirala, consultant interventional cardiologist from Hyderabad, but due to some emergency case, he couldn't join today's program. So to fill in the gap, Dr. Prafulla Kerkar sir has agreed to share some of his experiences around today's theme. So thank you for agreeing to share your experiences on such a short notice. Let me brief you all on the agenda for today. We'll kickstart the program with the opening remarks by Professor Kerkar. Then it will be followed by the first case. 10 minutes we'll have discussion and 10-minute case presentation and 10-minute discussion amongst the all faculty members. Instead of second case, Dr. Prafulla Kerkar sir will share few of his experiences, and then we'll have concluding remarks by our esteemed course director. I would also like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Thank you, Dr. Sachin Suryavanshi sir, Director Medical Affairs at Emcure, for joining on the faculty link. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request audience to put their questions in the comment box so that we will be able to take up those questions at the end. So I request Professor Kerkar sir to share his opening remarks and set the context. Over to you, sir.
Yeah. Fine. Well, thank you. Thank you, Dr. Shivale. I'm sorry. So, yeah. So, thank you, Dr. Shivale, for those kind introductions. And it's a pleasure and a privilege to be a course director in this meeting with an esteemed faculty moderators like Suri and Dr. Vinod Kumar. And of course, unfortunately, besides Abhishek Chaklecha, the other speaker ain't going to be there. Now, for the benefit of audience, obviously, some of them who may have been part of this, no thrombosis all started with that NO in the middle, and thrombosis is also because of the fact that we know Emcure has a big portfolio of thrombolytics as well and every other anticoagulant that they have. But we have moved on to just thrombosis is the end result of what is underlying is atherosclerosis and how to tackle atherosclerosis. So thereon the theme changed to doing interventional cases. That's what we cardiologists are. Of course, in the today's first case, I suppose it's a challenging case that Dr. Abhishek Shaklecha is going to present to us, where we decided calcium modification as a meaning that we encounter every other day. And calcium in a atherosclerotic lesion poses a lot of challenges. Good old days when we didn't know much about it, we used to just meaning break the calcium with unyielding calcium. We wouldn't do anything about it, but break it, dissect the artery, then stent it. That's how when I in my training days. But since then, calcium handling has come up in a long way in the sense that the biggest problem about calcium is that the stent continues to remain under expanded and gets deformed and could even get damaged, and with that the long term outcomes are never great, right? So on the equivalent, when you see calcium in the aortic valves, so good old days, my training days, I remember we used to just dilate every other aortic valve and then they used to come back because of the calcium. And then came along the towers that we heard about, and one of our speakers is one of our moderators has also done the first amongst was been with the first tower that was done. So calcium handling, when it comes to calcium handling, good old we could have balloons or rather specialized balloons, right from we have the non-compliant balloons of good old days, which you could take high pressures. Then we went on to non-compliant balloons of the OPN types, which would go up to 35 atmospheres. Then we had modification around the balloon in the form of using balloons which had blades in them or they had wires along with, so that those were designed only to cut through the calcium, right, and fracture the calcium, and not necessarily to dilate the vessel to the fullest, unlike the non-compliant balloons. Each has their pros and cons. During the course of the next case, we could discuss that also. And then the most important specialized balloon is the IVL, as we call it, taking from lithotripters in the kidney stone scenario. We have similar acoustic shock waves to break calcium. So that is what is IVL all about, intravascular lithotripsy. And we could discuss, because the cases today are calcium modification with this. And of course, then we've always had the ablative techniques. The ablative techniques means good old rotablation, right? So which still is so handy, yeah? Non-crossable lesions, and meaning where balloons even don't go wire across, and we can get in and drill through and then create space and go in. And then we have another ablative technique, or whatever we call that technique, is LCA, the laser. The laser strictly is not necessarily for calcium, but non-crossable lesions as a part of the calcium armamentarium. You could use laser to begin to create a space and then do it. Those are also there anecdotally, but laser not really a part of this. And of course, orbital atherectomy, I forgot, which is also available. I'm sure our young budding, our moderators, like especially Suri, may have used orbital atherectomy also. But anyway, today's session is not about atherectomies. It's more about IVL, the intravascular, which is actually a very simple technology, isn't it? Just to get the balloon. But yes, IVL balloons may also not reach go across the calcific lesions, so especially the tighter ones, and pre-dilating for IVL also. So we can have a lot of discussion on it, and it's nice to invite now, without much ado, Dr. Abhishek Saklecha, who is in a neighboring town from Mumbai, that is from Pune. Let's hand over to Abhishek Saklecha. Over to you, Dr. Abhishek.
Good evening, Kerkar sir, Suri sir, and Balkrishnan sir. And I would like to thank Emcure for providing this wonderful opportunity. Kerkar sir, you have been a teacher during MBBS and MD days. I've done from KEM. So it's
lovely.
an honor to be presenting in front of you. Shall I share my screen?
It's our misfortune that you didn't continue at KEM for cardiology.
Yes.
Never mind. Pune's gain and Mumbai's loss. Go ahead, please. Yeah.
Thank you, sir. I'll share my screen. Is it visible?
Yeah, sir, please make it full screen.
Good.
Yeah, we can see.
Start from the beginning.
Yeah.
So today I'll be presenting a complex PCI case in which we used a multidisciplinary approach. Coming to the case, he was a 68-year gentleman, diabetic, hypertensive, known case of chronic obstructive pulmonary disease, ex-smoker, and he's a known case of CKD on maintenance dialysis. So he presented with non-ST elevation MI in January of 24, presented with acute decompensated heart failure with initial drops of 500 and serially rising to 8,000. So he was stabilized initially with sessions of hemodialysis and non-invasive ventilation, along with anti-platelets and anticoagulants. So initially, he was planned for medical management due to multiple comorbidities, advanced stage and chronic kidney disease. But he used to have recurrent rest angina. So after discussion with the attendants, he was planned for a coronary angiogram. Echo was showing EF of 30% with global hypokinesia. This is the ECG of the same patient, sinus tachycardia with ST depression in the inferior lateral leads. This is the echo report. We proceeded with the coronary angiogram via the femoral route, as we also wanted to check the renals. As we can see, there is a diffuse atherosclerotic involvement of the iliofemorals, right iliofemorals. Coronary shoot shows heavily calcified left coronary artery, a short left main, and a severe proximal calcific LAD disease. The distal LAD is diffusely diseased, diffusely narrowed. There's a dominant circumflex with distal severe disease, diffuse disease. The right coronary artery non-dominant is totally occluded. We could not find the renals, probably they were totally occluded. So with this background, he was having multivessel disease with critical proximal LAD stenosis and with multiple comorbidities, COPD. He was a surgical turndown mainly because of COPD and chronic kidney disease on maintenance dialysis. So he was planned for a PCI to LAD with calcium modulation using intravascular lithotripsy. Rotablation was not planned in this case because of the low LVEF. So the patient remained stable after the coronary angiogram for 2 days. But on day 3, we noticed a right groin hematoma with a weak distal pulse. And in the reports, there was a hemoglobin drop significant of 4 grams. So at that time, heparin, which was ongoing because of the acute coronary syndrome, had to be withheld and a compression dressing was applied. Because of the sudden hemoglobin drop, we had to transfuse in to packed RBCs during hemodialysis. The USG of the right groin was performed, which showed a hematoma as expected. Along with, to our surprise, there was a right superficial artery, superficial femoral artery thrombus. In this case, we had to again continue the heparin, even though there was a hematoma, managing the bleeding risk. So he also used to have intermittent chest pain in between, and he was managed with anti-anginals. This is the USG report. So what could be the possible reasons for the groin hematoma? As we saw in the femoral angiogram, there was a diffuse atherosclerotic involvement of the iliofemorals. Also, there was a continued heparin and dual antiplatelet, which we had to continue because of the acute coronary syndrome situation. And also, CKD patients, they tend to have an unexplained bleeding diaphysis. What could be the reasons of the intra-arterial thrombus? So there was a diffuse atherosclerotic involvement in the ilia femorals. So which could and because of the arterial puncture, there could be a plaque disruption and leading to the thrombus formation. Also, there was a sluggish flow because of the extrinsic compression after the hematoma, and also the blood transfusion and acute coronary syndrome could cause a prothrombotic milieu. So that could explain the intra-arterial thrombosis. So the hematoma was treated with compression dressing, local heparin ointment, and IV anticoagulation. With this, the distal pulse started improving in next 2 to 3 days. The hematoma showed signs of healing, but the patient used to have intermittent chest pain. So even seeing this complication, it was decided to proceed with PCI. PCI now was preferred by the radial access in view of the prior femoral complications. As luck would have it, immediately before the PCI day, he again had a melena, which was brought to notice by the patient, and there was a significant hemoglobin drop. So for this patient, again a gastroenterology consultation was done. Pantoprazole infusion was started, and upper GI scopy was along with the colonoscopy was performed. Upper GI scopy showed patchy erosions and hyperemia in the antrum, and colonoscopy showed a colonic polyp, and for which biopsy was taken, but later it was proved to be benign, and a small intestinal bleeding could not be ruled out because it was not possible to scope that. So patient continued to have intermittent chest pain, hence his PCI was warranted. This is the endoscopy report. So in this case, we had to strike a balance between the ischemic burden and the bleeding risk. So ultimate goal of any procedure or any treatment is to cause symptomatic or mortality benefit without causing any harm. So also in this case, the reality and expectations of the relatives had to be set right. So patient expectations are generally that PCI is going to make the patient live longer or make him immortal. But in particular, in this case, PCI was just going to help him for symptomatic benefit of chest pain, and overall prognosis was guarded only because of the multiple comorbidities. So IVL was the preferred calcium modulation strategy. There was no rota because of the low EF, and stent choice was a bare metal stent, even if in this drug-eluting stent era, because of the active bleeding. While accepting the risk for ISR, the patient was not expected to have a long life, so we could easily accept the risk for instant stenosis. So we proceeded with the PCI. During PCI, the IVL balloon had to be modified to 5 pulses per cycle, because as we pre-dilated during the bed preparation with a 2 mm balloon, the patient had a severe chest pain and hypotension. So we modified the pulse cycle to 5 pulses per cycle. So the entire 80 pulses had to be delivered to the proximal LED stenotic site. After that, there was a significant increase in the minimal luminal area. We did not have imaging because of the financial constraints. Then after adequate pre-dilatation, 3 into 24 BMS was deployed. So, and after the BMS 10 deployment, this is the final result. This is the pre and post PCI result. So just a little bit of discussion after this case about what is CHIP PCI. So there could be 3 factors, patient-related factors such as active malignancy, liver cirrhosis or hemodialysis or pulmonary disease or past cerebral infarction, and as well as frailty. These factors and some factors related to the complicated heart disease such as EF less than 40, and unstable hemodynamics, and some factors related to the complexity of the PCI. Suppose if there is a left main disease or a chronic total occlusion or use of atherectomies or a 3-vessel disease. So if all these factors are there, then that is a definite CHIP case. So what could be the criteria for a high bleeding risk? The major criteria are use of long-term anticoagulation, severe liver or renal disease, hemoglobin less than 11, and spontaneous bleeding requiring hospitalization, and platelet count less than 1 lakh, along with other minor factors such as age more than 75 or borderline low hemoglobin or long-term use of NSAID, steroids, or any history of ischemic stroke at any point of time. It could be also determined by the ABO algorithm. A stands for age more than 75, and advanced stage more than 85, along with the age more than 75, along with frailty or a life expectancy less than 1 year. B stands for bleeding. So if the patient has a spontaneous intracranial hemorrhage or a recurrent GI bleeding, or a hemoglobin is less than 9 grams per deciliter, or organ failure, if there is an end-stage renal failure or liver failure or a bone marrow failure with a platelet count of less than 50,000, and a stroke in the last 6 months. So these are all the risk factors for a high bleeding risk, like advanced stage renal disease, liver disease, active malignancy, anemia, low platelet count, simultaneous use of oral anticoagulants, use of NSAID, steroids, and prior bleeding or transfusion history. So in this case, we faced multiple clinical dilemmas. So the first dilemma was whether to intervene or manage conservatively, considering the high-risk clinical substrate. The next dilemma was there was a groin hematoma as well as an intra-arterial thrombus. So whether to give anticoagulation or not. There was a high bleeding risk with the serial hemoglobin drop. So whether the patient could sustain a dual antiplatelet therapy or not. What could be the stent choice? We had to balance the risk of stent thrombosis with the risk of ISR with bare metal stent. Whether to intervene in this admission or do interval procedure in view of multiple blood transfusions. So as we all know, multiple blood transfusion in itself is a risk factor for stent thrombosis. So what happened post procedure? So post procedure, patient's chest pain obviously resolved, and patient was hemodynamically stable. A routine hemodialysis was done post procedure for the contrast washout. But again, the patient on day 3 landed in pulmonary edema and fluid overload, for which he needed a urgent hemodialysis at night. The ECG was fine, and then after that, the patient was stabilized and discharged. Again, as luck would have it, after 2 weeks, the patient started feeling breathless. We investigated, did an echo. The echo picked up a large pleural effusion, and after that, he had to be therapeutically tapped. It was a uremic and transient effusion. So he did well for a few months, but because of the multiple comorbidities and chronic kidney disease, he had a bad urosepsis 6 months later after the index procedure, and he succumbed to that. But so what would be the take-home message from this case? So a CHIP PCI can be performed at the tertiary care institute with the use of appropriate technology and with multidisciplinary approach. Like in this case, we had the involvement of the primary physician along with the nephrologist, gastroenterologist, radiologist, critical care team. So a shared decision making was important in this case. And complications are frequent in high-risk patients, but early identification and management is essential. And to say last but not the least, cardiac intervention should not be denied in patients with chronic kidney disease or a high bleeding risk patients. Instead, a tailored approach striking a fine balance between bleeding and ischemic risk and CIN and risk and ischemic risk is essential. So that's my case.
Yeah, that is indeed. Yeah. Okay, so the case is open for discussion. We have our moderators also here. A few points that I thought we could discuss around. And that's, in fact, at the outset, it's a very challenging case and very well done case, I would say, in spite of the limitations. Only thing is that, of course, we can discuss that you said that there was no imaging done, and whether calcium modification in the absence of imaging, how much can we really modify the calcium without imaging, meaning whether we can use the right tools or otherwise, that we will discuss afterwards. But from the audience perspective, now you said that this about the challenge of diagnosis itself, right? You had chest pain clear cut out here and everything going around, but it was an end STEMI, so to say, like troponins were elevated, ECG is not a STEMI, and then subsequently you have had a serial rise in troponins, suggesting it is the anterior injury. And I forget what was your echo in the I didn't realize that. Was it just global
There was a
hypokinesia?
global
There was a global
hypokinesia.
hypokinesia. The challenge about the diagnosis is just, and you mentioned ADHF, so it's probably been in heart failure diagnosis from before, right? It's not acute heart failure like you would get only in ACS. So that can be challenging, but here in that there is a culprit there, and how early can you make him fit to do an angiogram? An angiogram is mandatory, and I suppose you did it after a little few days after the
Yes.
intuition, right? But pre-discharge, very few, even in the Western world, very few acute decompensated heart failures get an angiogram before discharge. And yours was a perfect scenario to go ahead and do the angio. Having said that, because of the chest pain, now I would bring in my moderators also. Today, the modern guidelines, do they really talk about before you get a picture? This guy's first time he's getting a picture of the angiogram, right? Whether a dual antiplatelet strategy before going in is necessary. It is not necessary, is what, unless it's a STEMI, right? Yeah, you have views on it, because one of the contributors is that he's on heparin as also a dual antiplatelet. That could be it. Then going to the groin hematoma, where in today's days, at least, we are old school. I still stick and I don't waste time on an ultrasound, at least angioplasty wise. But as a routine, where it's a high bleeding race case, and that pictorial that you put up from BARC, the group, that pictorial, I have actually got it stuck into my cath lab. So, or for the matter, more so in the fellows room, where they need to do that as a checklist. We don't do scoring and all that, but as a checklist, you have the elderly, you have comorbid conditions, and you have bad, even anemia itself is a high bleeding risk, right? And CKD, etc. So that pictorial is very good, what he showed. So I'm just thinking aloud whether dual antiplatelet upfront, whether it is needed, and transfemoral, a puncture there also with an ultrasound guidance. So my moderators could come in, Dr. Pawan Suri first. And what do you have to say about this aspect before we go to the interventional aspect? Also, because we have time on our hand, given that we would have the other gentlemen
So
speaking.
we have a single person only.
Yeah, that's right. Yeah.
Dr. Abhishek, welcome, boss. Nice case. Couple of queries and couple of doubts in this case. The first one is, why didn't you start with the radial rather than the femoral? Because the patient had a chronic kidney disease. The patient was, frail. From the history what you have shown to us, the patient was more or less a frail patient. So in these patients, we are almost 95, more than 95, 99% patients we are doing the radial now. And ultimately, you switch over to the radial. By doing the radial, you are lessening your complications. That is one thing. I feel you should have straightway gone with the radial rather than the femoral. That's one. The second thing, without imaging, I don't feel the calcium was so hard as to use an IVL. We have been, as Dr. Professor has rightly said, we have been using the IVL has come in limelight for the last few years only. We have done the CTOs, the calcified lesions with balloon angioplasties only, and then we have put the stents. And I don't feel from the clinical picture or the picture of the LAD that IVL should have been used upfront. You should have done the ballooning, because the cost factor, because you knew that the patient is not going to do good in future. The survival was almost less than 1 year.
Yes.
It was evident from the multiple history because he had melena also, then he had the erosions in the GI tract, then he had CKD on maintenance model, the COPD patients. So we could make out the picture how the patient could look like. So the survival was not more than 1 year. I feel that should also have been kept into consideration. The third thing is before going for the stenting, I feel this patient should have been put on the anti-anginals, the high doses of anti-anginals, rather than going for the intervention. The problem in today's technology, we are so much we are over-informed. The problem with the social media is that we are over-informed and we are over-enthusiastic about the things. The fact is that we don't have a control over the life and death of the patient. And putting the stent was not going to give him any survival benefit. It was only going to give him a symptomatic benefit. Rather than going for the symptomatic benefit and by putting on the stent, I feel the better approach would have been to put him on a good high dose of anti-anginals, watch for a month or so, and then go ahead with the stenting. The fourth thing what I want to talk about this case is, now we have the DEB also, drug-eluting balloons. So in that scenario, when you have a high bleeding risk patients, so you can put the DEB and you can stop the antiplatelets after 2 weeks or 3 weeks. So these are the 4 points I feel we should have kept into consideration in this patient. But otherwise, a very nicely done case, a very challenging case, a frail patient, then you have to talk with the attendants, then you have to satisfy them, then you have to take care of the patients. So a very cumbersome job, I feel, Dr. Abhishek, you have done.
So it
That's
was
Yeah.
thank you,
So, Dr. Vinod Kumar, you have anything to add on the case?
Yeah.
I was just talking not interventional. I was just saying going up to intervention, even from the audience perspective, a diagnosis on the basis of that ECG, just heart failure can give that kind of an ECG, right? But of
And-
course, there was a tight lesion. There's no question about that, right? So you had a tight lesion to give
And
an
Dr. Praful said the patient had already the CKD patient. So troponin I was done or troponin T was done.
sir, troponin I. It was troponin I.
So sometimes as Dr. Professor has rightly said, sometimes the myocarditis also, the the pericarditis and myopericarditis can also give the elevation in the, and you did not have on the echocardiogram, you didn't have the definite regional wall motion abnormality. You had a global hypokinesia.
So and one more thing was that double antiplatelet that I'm talking about. There is absolutely, because it is difficult to unlearn what we were doing all this,
Yeah.
right? So there is no need to do dual antiplatelet till you have seen a picture, right? Yeah, because we have potent ones to give up.
That too, in a CKD, long-standing CKD patient, we
Yes,
expect to be most probably triple vessel disease. In most
Exactly.
times, it's better to go with a single antiplatelet therapy. And I strongly believe we should have gone with an ultrasound in the femoral pic. And post-angio also, there is no picture of the femorals. While
So
coming
we
out,
are-
have taken a shot because there's a 4 grams drop in hemoglobin. It's a very significant loss.
Exactly.
Again, going ahead with I feel imaging is much cheaper. That is, IVUS is much cheaper when compared to an IVL. IVL costs you about 3.2 lakhs, and imaging is we can do IVUS at around 60,000-70,000 rupees.
Yeah.
A simple pass
Maybe
run
you
of
could have you could have avoided IVL altogether.
IVL also.
Possible.
But
But
past IVUS catheter, we will know how far we stand, what is the calcium load. Whether we could have come out with a cutting balloon or something like that. Then why do you want to go with bare metal stent? You want to reduce the bleeding risk, right?
Exactly.
Yes.
How long do you want to give antiplatelets? Leave alone this. If you want to give antiplatelets with the BMS, how long you want to give antiplatelets, man?
So the thought process was like to stop antiplatelets when as soon as possible as we could, because there was as you saw from the case, there was active GI bleeding.
Yeah. So I
just
just
before
want
the
to make you clear that
there
none
was
of
a torrential bleeding, and then I could
no.
just stop the antiplatelets.
Yeah. The thing is, that is the old school of thinking. Now there are a lot of trials with us.
Cypher Texas days.
Starting from
Cypher Texas days was BMS versus
so many
this.
trials are there which states that DES scores over BMS in even a short-term duration. See, BMS, we need to give dual antiplatelet therapy for 30 days. In DES also, in high bleeding risk patients, now we give only for 30 days dual antiplatelet therapy. If you want to reduce, really, it is your concern is only of dual antiplatelet therapy, then DES, BMS will not make a difference. procedural outcomes are going to be better with DES rather than BMS. As mentioned by Dr. Pavan, sincerely, if you wanted to avoid a stent, then antiplatelet therapy, then you should have gone with a DEB rather than going for a stent. The only concern here is the proximal modes segment. If it is a mid or distal segment, we have a lot of documentation or papers which suggest DEB is preferable. Since it is a proximal LAD, that is the only significant worry whether we should go with DEB or not, since currently guidelines are not supporting it. Otherwise, for reducing the duration of dual antiplatelet therapy, choice of BMS cannot be attributed in a current era of knowledge. What we have from multiple RCTs.
During the intervention part when to discuss, I was going to come with that BMS thing. I had actually jotted it down. So now having said that, let's forget what could have been done, preventive strategies we have discussed. And in the preventive strategy, from what as Dr. Vinod Kumar points out, nowhere today BMS is required for a short-term this thing. In fact, the Twilight, TICO and everywhere. And in fact, the guidelines themselves allow you to get rid of be on only dual antiplatelet for as short as 4 weeks. Yeah. So that is what it is. And preventive strategy wise, ultrasound use would have helped you. And of course, class 1 indication today is to go radial in a ACS scenario to prevent bleeding, as also from outcome benefit wise. So now having come to IVL, asking the nuances of IVL here. Now IVL wise, now of course, you angiographically estimated what as being your artery size. And how did you choose the IVL balloon size? So that is what it is. So we tend to choose a 1:1 reference vessel to this IVL because you want to oppose well here. And of course, you did it right, only 4 atmospheres. That is important. Good old days, they used to do it. When they started, it was 6 atmosphere. But then perforations increased with 6 atmospheres compared to at 4 atmospheres. That is one thing. Then you mentioned the aspect about whether that 5 pulses only you gave rather than 10, 10 pulses. Is there anything? How do you go about, Dr. Suri, if you were to do an IVL? Do you change your pulses or otherwise? I have had one patient, in fact, one of the patients that I show, I might get a chance, just have just angio films to show. I don't unfortunately have any IVIS films, so therefore let us not get into that. But you may get vagal, you may get across your balloon occluding, you just the shock, especially the first shocks that you give, you may get some bradyhypotension also. But does that make a difference as to how many you should give, 5 versus 10?
See, Dr. Professor has rightly said that initially when the IVL was brought into the market, they were of the opinion that we have to use the more pulses, about 6 to 8 pulses you can use. And you can inflate up to, you have to use the balloon in the ratio of 1:1 balloon to the vessel size. Then in one inflation, inflate about 4 atmospheres or 4 atmospheres, and then give the pulses of 6 to 8. But with the introduction of the imaging, especially the OCT, we have seen that about 5 to 6% of the patients in the acute coronary syndrome, they have the calcific nodules. So these nodules were the culprit lesions which were asking or which were doing the perforations in these patients when we were hyperinflating the balloons. So when you do an imaging, especially the OCT, and you find that there is a calcified nodule, in those scenarios, you have to reduce the pulses to about 4. This is the SCAI recommendation 2024. So if you do an imaging and you find the calcified nodule is there, you just reduce the number of pulses to 4, not to the 6. So you have to reduce in those scenarios only. It is recommended that you have to reduce the number of the pulses. So regarding the other part, what Dr. Professor has said, that if you get the bradycardia or if you get some sort of hypotension, that is part of it, because you are inflating the balloon and it is giving the acoustic sounds. Actually, it is acting like it is producing the sounds and it is breaking the calcium. So these things are going to happen. Some calcium is going to break down. It is going to come the superficial calcium that is going to the vessel. So it is going to cause the bradycardia or hypertension. So that is part of it that can be taken care of in the meantime. But that should not hinder you from increasing the rate of these inflations in the IVL.
So, yes,
Sir,
Dr.
put
Kumar, you have to
my-
say anything about the technical nuances about IVL.
Yeah. See, what I feel most of the time, I choose IVL in patients who have a deep calcium and longer length calciums. Most of the time, my tail muscles are not sufficient for me. I'm not left to somewhere where I choose to lose So otherwise, I do
You mean
WSL-plasty.
cycles.
I
You mean
preserve it
cycles.
for RCA or circumflex LAD. So every time I feel that if there are, I used to tell the company, you should increase the number of pulses. They would be telling next year, by next year it will come, sir, like that. So like peripheral, we should have more number of pulses because we choose 3 lakh device and we don't go and waste 5 or 6 pulses and come out. Most of the cases where we genuinely we choose this thing, we use them almost every time the full 10 pulses. Probably not at the same place, but at the different places, at the different level
That's,
lesions.
yeah,
That's how.
that is very important. You know, if you have to, basically the study or the learning is that you have to start initially with a reduced number of pulses, then you have to increase it, but don't focus increase the number of pulses at one point. You have to move it proximally and distally, then do it. You can go up to the 10. So never C2 version of the IVL has come where you can deliver up to 120 shocks. So initially it was 80 shocks, now you can deliver up to 120 shocks. So you can shock the whole vessel. If you have a full calcified vessel, you can shock the whole vessel. And the only thing is, I agree with Dr. Vinod that we can go up to the 10 pulses. We have used the 10 pulses, but it is not that you start with the 10 pulses because especially when you're not doing the imaging, you're not sure about what kind of calcium it is there.
Imaging, without imaging, it is not a right.
Imaging, it is not possible to go up to the 10, but you can start with the 4, you can start with the 6, then you can move proximal distally and then increase the size.
Yeah, having said that, among the imaging modalities out here, obviously with the contrast issue, with the CKD issue, OCT was kind of out here, and IVUS guidance, if at all you could have, and it would have been nice to do that.
Sir, it was
So, yeah.
It was advised, but as they were not financially very sound, I told them you do the therapeutic modality first. And
Dr. Abhishek,
if you can, then we'll do
Dr.
the
Abhishek,
IVUS.
Dr. Abhishek, they could afford IVL. I feel they were financially stable.
No, no.
Very
So
expensive
I had to wait for 8 to 10 days for them to arrange the finance.
We are also doing intervention in the same country. We know IVL people, how we convince the people about IVL.
I know. Yeah, having said that, I was asking now in terms of the calcium distribution and this thing, in an ideal world, this is one of the best modalities for a circumferential calcium, but nodular calcium as well as eccentric calcium, one can address with IVL as well. That's what it is. Yeah. So in terms of the balloon rupture wise, how often have you encountered? I have not encountered a balloon rupture as such, but have you encountered balloon ruptures are said to be commoner with shockwave balloons rather than with even the OPN balloons? Balloon ruptures.
I have encountered one.
I had one with the IVL, but OPN I didn't.
So I haven't
very
encountered
initial
one.
stage.
Yeah.
My second case with IVL, I had a rupture.
So now,
then we were on the same page. My second case was at the same. Then I called the company where this is the problem with your eye.
Same thing.
So I haven't yet
probably your
encountered, not
assistant
that-
would have deflated early, sir, before the phone goes off.
Maybe I feel I don't remember exactly. Maybe we were enthusiastic about using the more pulses. That's why it got burst down.
So that time we were using 6. So the intention was new, no. So I want to go with 6. I want to. So would be that. That company person was saying me probably your assistant would have pulled or you would have deflated early.
There are a lot of reasons they can tell you.
Yeah, that is very, very early stage. When they introduced it, we had this issue. But after that, probably with only 4 atmospheres, we are not finding much of the difficulty in use.
Having said that, now for IVL wise, you would require pre-dilate. The company guy who is there in the lab, he insists that you should pre-dilate, which I have done all by and large. So pre-dilatation is required. That's what it is. And if it's a very tight one, so your balloon may not yield, in which case you will still have to be comfortable using rota again. Right. Yeah. And of course, here because of the hypotension that would have happened. Now, in this particular case, had we to use a rota, would you have used the usual cocktail? We have given up with the usual cocktail. What about you guys? Here, both of you moderators, meaning hypotension becomes a worry with a acute heart failure.
Yeah. It becomes a worry. But with the Rotaglide, I feel
with the Rotaglide, all this is not necessary.
This is not necessary, but when you are using the cocktail, the Indian cocktail, what we use we put this is for the learning purpose only. We put about 10,000 units of heparin and unfractionated heparin and 1 liter of saline. We use about 400 micrograms of nitroglycerin and 10 milligram of verapamil or deltism.
Yeah, that's
So
all.
these are all hypertensive agents. So they cause the hypertension, and the slow flow is also there. With an ejection fraction of 30%, the problems are going to increase in that scenario when you're using the cocktail.
Sir,
Dr.
kind
Abhishek,
of
did
sick
you have to
patients, rota
pre-dilate in
played
this?
is the choice.
Yes, sir. I did pre-dilate, and that's when I could identify that is the culprit. Because when I pre-dilated, there was sudden chest pain, hypertension. I pre-dilated with a 212 balloon, and the balloon, IVL balloon, was 3.
Okay.
Yeah.
Abhishek, we all know that is the culprit. There is no doubt.
Hmm.
Whether it can be maintained in anti-anginal, that is the question. If in case medically, if you want to manage,
So,
whether it can be because
so
the
that's
mobility is
what
going to
we,
be extremely low.
yeah, correct, sir. So that's what we tried
That
in
is the
this
only
case.
aspect. Otherwise,
That's
what
we
you have done is right. There is no doubt.
See, the only thing when you are when
Even I was not sure about the culprit, sir.
Yeah.
But then when I pre-dilated, because he was having diffuse disease, global hypokinesia, even the right corner he was totally occluded. Circumflex was diffuse disease. So there was a doubt in my mind as well as to what is the culprit. But when I treated the lesion, I was sure that was the culprit.
See, Dr. Abhishek, no, we are not only the doctors, we are the social doctors nowadays, and you can see the anger the society has towards our
Right.
fraternity is too much. And especially when, the problem has arisen, it is not arisen because we are at the fault or we are doing something wrong. The problem has arisen because the technology has become more expensive for the
Correct,
patient,
sir.
because
Correct.
patient has to take everything from his pocket. So
Yeah.
that is the problem, and that is why the anger is against the doctors. It is not that we are doing something wrong or we are doing something unethical. It is only that the cost involvement has increased because of the increased advancement and because of the better modalities of the interventions. So in that scenario, also we should matlab, safeguard ourselves also. And
So that's what
person
I
can
told.
die. I can give a lot of examples. Person can die because of anything. He can die because of a bleed. He can die because of, renal failure. He can die because of intracranial hemorrhage, anything. But once you have done an intervention, everything goes to the stent. Everything goes to the stent.
Mhm.
So my suggestion to the younger colleagues is that don't make that scenario where the people get up and they say, yeah, this stent has been put in, that's why the problem has arisen. We were already knowing the mortality in this patient.
Correct.
And if the attendants force you doing the things, then it is okay. Everything is written, everything is documented, everything is signed.
Mhm.
But the thing is, never push the patient to do the things because your intention is to give the best to the patient.
Yes.
But your intention is seen by God only. Your intention is not seen by the attendants and the patients.
Absolutely.
Your outcome of the patient is seen by those, not your intentions. So if I would have been at your place, maybe because we have aged now or we are less enthusiastic, it is not like that. But with the experience, the time has come. Now the time has come where you have to selectively choose the patient. If a person stenting collapses after 6 months, you have done an intervention, everything goes to the intervention, everything goes to the stent. They forget about the kidney, they forget about the marina, they forget about the GI bleed, they forget about everything. So this is the suggestion for the younger colleagues, the dynamic, because you people are doing the wonderful job. Because when we were doing an intervention, when we were learning the interventions, so we were the old school people, doing the ballooning, and we were happy. Okay, this balloon. Then came the OPN, as Dr. Professor has rightly said. Then came the OPN. We were happy. Oh, OPN has come. Something has come to our rescue. Now you have a lot of things to your rescue. You have an IVL. Think about the times when we had the rota only, and the complication rate of the rota, tremendous. The burden when we had to do the rota, those in two nights we used to think about it. Yeah, rota karna. And now you go in the cath lab in the morning, patient comes, you put an IVL, come back, patient is happy, you are happy. That's fine. So the things have changed for the
The angioplasty has become
My
an
chief used
easier
to say,
science.
patient should earn the procedure.
Yeah.
yeah.
So
Patient should
now
learn the procedure.
Should earn the procedure.
all
Otherwise,
of us faculty on harping on the what you call imaging. So today's days and time, you spend that extra on imaging, as was Dr. Vinod Kumar said, and then basis the imaging. When would you choose all this armamentarium? We are spoiled for choices today yet, right? Old school balloons are also available. Everything is available. So when basis your imaging, I also feel sometimes that imaging shows too much. Okay.
Yes, yes.
And good old fluoroscopic calcium we saw and then decided what to do. We just put in a balloon that is not yielding waste-wise. It will not yield at higher pressure. We go high, non-compliant balloon, and then we resort to something else. So imaging-wise, how does it change your thinking process, Dr. Vinod Kumar? So what do you really,
I
in
strongly
this
believe.
particular case, for instance, you're doing an imaging and you've seen something which will make you do a particular kind of calcium modification technique.
Okay. So depends upon the nature of the length of the segment involved and the degree of calcium. So probably we are going with
But what about the
IVUS.
thickness of the calcium?
Thickness, probably it is going to be on the
It's
higher
only
side.
OCT
When we
that
are
gives
doing
you the real
IVUS, we
thickness.
will not be able to measure effective thickness of calcium. But if it is a circumferential more than 180 degree calcium, then 100% we need some kind of modification devices. Since this patient life expectancy is on the lower side, if possible, I would have used a cutting balloon in case. If not, then my next choice would have been a rota. Because
One
cutting balloon or
important thing
not,
here, I'll
yeah.
just intervene. One important thing here is cutting. You'll obviously get the sizes of the vessel throughout, right? On the
Yeah.
imaging, that's important. But with a cutting balloon, there is a important caveat there that you should undersize for a cutting balloon, right?
Yeah, that we will do.
Yeah, as against an IVL where you want to be 1:1 sizing wise. Yeah, go ahead, please. So you would have used
I
a
will
cutting
first, my
balloon.
preference would be cutting balloon. If I have to do the intervention first, then I will do an imaging. If the IVUS shows a significant calcium burden, then I will go with cutting balloon. If it is probably 260 degree like that, then with rota glide I would have tried rota, sir. Because cost wise, rota is much cheaper when compared to IVL. So I would have finished this entire setup in that. Only 1 or 2 runs. It's only a proximal segment. It is not distal. I'm not going to go for a 2 runs and all. It's a single run, very, very proximal. So I can do it, though there is a significant LV dysfunction EFS 30, but it's only LAD. So we should be able to do. And a couple of passes, only few passes. Then I would have cut with a cutting balloon. We have a lot of bow cutting balloons. By the time it would be open, so the cost also would have been reduced. Then we would have come out with a stent. This I would have done that way. My option of going in for IVL, I would have not been able to convince that particular patient for that. But I would have 100% convinced them. If they are not opting for imaging, I would have not touched this patient. That is for sure.
Okay. What
I will
about
not do it.
Dr. Suri? Dr. Suri?
Sir, I
You
definitely.
have done procedures without Doctor. I
Sir.
think you're talking about age. I'm the oldest out here. You're the second, and then
No,
probably
sir.
Yes,
Vinod
sir.
Kumar.
Sir,
So
Sir,
you do it
in
without
this scenario,
Sir, Dr. Prabhu sir, having hair on the skin does or not having hair on the skin does not make one old or young.
Okay.
Yeah.
Just
So that is not the criteria, sir. So you are still young and dynamic, sir. We know.
okay. Okay.
The-
Go ahead.
regarding this case, definitely speaking, sir, I would have put this patient on the conservative management.
yeah.
I would have put this patient on the conservative management, sent patient home for 1 month, put on good anti-anginals. Just I would have just got the time. ठीक है यार अगले महीने आ जाना 15 दिन खा लो 10 दिन खा लो 15 दिन 20 दिन खा लो I would not have touched this patient.
Sir,
But if I had touched,
learned from my teacher, sir. There is Dr. J.S.N. Murthy, very senior cardiologist in our department. He's 78, 75 around. So he keeps severe TVD patients with LV dysfunction, severe LV dysfunction on medical management. Not only the CKD,
exactly, I
most
agree.
of the patient.
I would have definitely put this keeping in the
Initially, when I was young, I used to do a lot of interventions for these patients.
So let's
Then,
keep the medical
when over a
because we
period
are
of time, I learned
doing
that
KT
this
live.
subset of-
So we
Yeah.
want interventional talk only. Let's
Okay.
keep that
Okay.
aside. That's a point well taken.
Now,
Even
that's-
Abhishek
that is-
Akshay is for it.
that is
But
that is
please
where-
साहब आप बोलिए ना imaging करेंगे तो
हाँ,
imaging के
that is
बाद
sir where
क्या करेंगे?
that is sir where I am coming. I would have preferably put this patient on the conservative management, but since we are talking on the intervention form, what I would have done, I would have just gone into the vessel, dilated it with the balloon. If the balloon would have dilated, I would not done the imaging, other things. I would just done the dilatation of the vessel, done the imaging to see if the dissection is there or not. If the dissection would not have been there, I would have left it like that with the depth. I would not have put the stent.
Okay, depth for a proximal LAD.
Yeah, I would have taken that
But
not in
then
this patient, though
today's
it's not
days and
recommended.
times,
Yeah. Though it is
days
not,
and times, this particular artery, it's very likely you may have dissected and you would have, with the, if you are resorted to imaging, you would have dissected.
sir, where
Then to put a
that is where I'm
proximal
coming.
LAD
Yeah.
without, just on a DEB,
Sir, that is where I'm coming. If I would have done the dilatation, I would have done the imaging. If the dissection was not there, I would have put the depth and then gone out. If the dissection was there, even if the type 1 dissection was there, then I would have put the duct-loading stent.
okay, great. That's a point well taken. Yeah, so I think everybody, one final, the real villain out here is the calcium nodule, right? Even if you manage to do it, it comes back with restenosis and you have nodules again protruding inside the stent, right? So how do you handle calcium nodule? Do you ever, after imaging, back out that there's too much of a nodule out here? And current ablative technology, you might get a bias going and yet be able to get the IVL to oppose it or whatever. So will you back out with a nodule or will you do it with a nodule?
Yes, we should accept, according to me, we should accept the result. If it is 80%, 80% expansion also, we should not fight with the nodule. Because if we fight with the nodule, I have had a LAD perforation in my patient.
Exactly.
So I have learned in a very hard way. I will tell my colleagues also, friends, juniors, that if there is a nodule, you should respect the nodule. We cannot go and completely divide or make it zero, a 95% expansion, 100% expansion or all. It's not possible. Once you are midway, you found that there is a nodule, you have to accept at least around 80% expansion is there. You should come out. That is what I am doing nowadays, because I burnt it in a live case in a regional meet. Was doing, I had a perforation. Everybody was saying,
Exactly.
take one more
Nodules
balloon,
are the
upsize. Everybody was saying. Then we went with the upsized balloon. The panel was saying to go for upsizing. So we went with the upsizing of balloon, patient had perf. So I strongly believe it is
But
better
yeah,
to accept.
I agree with Dr. Vinod that we should not play with the nodules so hardly, because perfection is not always right in favor of the patient. So we should not go for the perfection. But here I want to add one point, that in the era of the imaging, especially the OCT, when we are using optical OCT, we can more or less get or an IVAS also, we can get an idea about what is the content of that nodule. It is a lipidic content or it is a calcific content. If the lipidic content is there, more lipidic content in the nodule is there, that means it is more deformable, so it can go up to the higher sizes. But if you see that it is a calcific content in the nodule, that is a non-deformable, so you have to accept that thing. So it is not true in the current era, when in the times of the imaging, that you have to not play with the nodule. If it is a lipidic content, deformable, then you can go and dilate it. If it is a calcific content in the nodule on an image,
I'm talking about
then
calcific nodule.
if it is a calcific nodule, then don't play.
Because within calcific nodule also on an OCT, they talk about an eruptive
Eruptive and
versus a
non-eruptive.
non-eruptive. Whole lot of things are happening, but we are learning a lot. Of course, everybody is learning also.
I don't understand how much time we have to learn. We learn one thing today, and after 5 days, Abhishek comes with new technology. Then we have to learn it again. Then we have to update ourselves.
Exactly.
Because Abhishek
But
thinks
we
we
have
know
to-
everything. Because Dr. Abhishek thinks we know everything. Then we have to update ourselves.
Exactly.
There is a paper recently from Mehran. She has brought a paper on chronic stent recoil. Basically, chronic stent loss. A few weeks back it has come, and it talks about calcium nodule.
Exactly.
Post-image optimization they have done, and over a period of time it has come back, and it has gone for ISR in about
Actually, we
18%
have
of the
almost come to the end of it. I had something looking like a fluoroscopically also. We could figure out there's a nodule as a right one. And we did do the IVL. And at the end of it all, I'm sure this guy will come back. Everything is there, but little indentation is still there. Unfortunately, our eye was, because like quite tired by the end of the day. We didn't do a run afterwards, So that's what was one patient case that I would have shown you, because I was thinking what to do about nodule, and it was a very short notice, about half an hour, 45 minutes before I came to know, and whatever I could ask of my cath lab tech and come home, I couldn't put it together. But yes, we have learned a lot. Thank you, Abhishek. That was a fascinating case. At
Thank
all levels, there were discussion. Also, importantly, BMS versus DES, as what even Vinod Kumar pointed out, and we all feel that modern generation DESs are equal to. I mean, I don't think there is any role today remaining for BMS, except that if they are allowed available somewhere on somebody's shelf for 5,000, etc. Right? Because the modern generation DES is very much there for, meaning it's good DES and we get good quality DES all over. So with that, on a note that this learning knowledge, KNOW is more important. Knowledge keeps growing. This is knowledge-based webinar, and it's nothing to do with no to something and yes to something, though we heard about no to intervention itself, not no to thrombus being not there. Intervention itself, no, but moving from KT as being no thrombus to no atherosclerosis itself and the nuances of it and the various technologies of it. We had a very excellent session. Thank you, Emcure. Thank you, moderators, Dr. Puri Saab and Dr. Vinod Kumar. And of course, a big thank you to Abhishek and for the audience who are all a part of it all. I hand it over to Rahul. I think we were good on one case. There's a lot of discussion that happened.
Yes.
Otherwise, it would have been rush, rush, rush. It was nice. It was nice.
Thank you for the
And
concluding
Abhishek
remarks.
did all
Yeah.
it. Thank you, Abhishek.
I would like to express a sincere gratitude to our course director, Professor Kerkar sir, and our distinguished moderators, Dr. Pawan Suri sir and Dr. Vinod Kumar sir, for sharing their knowledge and expertise with us today. And thank you so much for the interesting case discussion around just a single case. And I think I am sure this must be a knowledge treat for the entire esteemed audience who have joined today. I would also like to thank Dr. Abhishek Saklecha sir for bringing an insightful case presentation, and your contribution has undoubtedly expanded our understanding around the case discussed today. I would also like to thank our esteemed audience for their time, continued love and support for No Thrombosis program. So thank you all once again for joining, attending and encouraging us. Good night and good time. Thank you.
you, sir. Thank you, Dr. Professor.
Thank
Dr.
you.
Vinod,
Thank you,
Thank you.
Professor.
Good night.
Thank you,
Thank you, sir.
Answer.
Thank you.
Good day.
Bye. Bye.
Recording stopped.